Welcome to State of Reform's virtual series, 5 Slides We're Discussing, with some of healthcare's most thoughtful leaders. And now, the host of State of Reform, DJ Wilson.
Well, now, good afternoon. Thank you for making time to be with us. My name is DJ Wilson, one of the hosts here at State of Reform, and we are super excited to bring you this conversation on the policy implications of new medicines. There are a ton of interesting conversations happening in this space, and we're excited to bring in a couple of voices to talk through just a few of them and sort of learn about their perspectives and the overall makeup of this super interesting space, particularly here in Florida. This conversation is focused on Florida. Of course, we've got a couple of great perspectives from the Florida healthcare space. We also have a national voice with us here. So without further ado, I want to jump right in and introduce you to our panel today. We've got Karen Van Kallil, the president and CEO of the Florida Alliance for Healthcare Value. Omar Rashid is a physician. He's a surgical oncologist in private practice, does services and has credentials at places like Broward and Holy Cross, and is the chair of the Southeast Florida Area Board for the American Cancer Society. And finally, Wayne Weingarten, who actually is a PhD and does get called doctor from time to time, is senior fellow and director at the Center for Medical Economics and Innovation at the Pacific Research Institute. Mouthful. Thank you all for being with us. I appreciate it. Let me ask you first, Karen, just to start us off, tell us what you are spending your mental energy on these days. Tell us about the work that you're doing.
Thanks so much, DJ, and appreciate being included in this important conversation today. So I run Florida's Business Coalition on Health, as you said, the Florida Alliance for Healthcare Value. And we've been around since 1984. We're a 501c3 research and education organization, and we're led by large public and private sector employers. We have about 100 employers in our membership, but we do work in a very multi-stakeholder way. We have in our membership healthcare systems and health plans and pharma and advocacy groups. And really, our agenda is driven by the needs of these self-funded employers and what they need to be able to put in their benefit design and their network and their employee communications to drive value. They really need to extract the most value out of every dollar, and that's probably magnified for all the public sector employers we work with, because here in Florida, there's not going to be a whole lot of opportunity to increase taxes so that they can cover the increasing costs of hospital and drug prices, for example. So what's keeping us up at night is how to combat the increasing cost of care. They understand how important it is to have a healthy workforce who can access preventive medicine, but also active treatment when they have been diagnosed with a disease or condition. So lots of work going on right now in this space, and look forward to sharing some of it today.
Yeah, great. Wayne, how about you? From where you sit, what are you spending your mental energy on these days?
Well, first, thank you for including me. It's great to be here. So I'm a senior fellow and director for PRI's Center for Medical Economics and Innovation. The Pacific Research Institute, we're a free market think tank located in California. We work on a wide array of issues at the state level as well as the national level. And one of our main focus area is healthcare, where we really are working on how can we improve our healthcare system, improve the delivery, the costs, the innovation, looking across a wide array of health insurance, the innovations in delivery of care, as well as medical devices and drugs and gene therapies. One of my research areas, one of the things that I've been really trying to address is how can we promote drug affordability while at the same time also promoting innovation, and really trying to emphasize that's the key balance that we need to strike, is that we need to make today's therapies more affordable, but at the same time not diminish the incentive for innovation so that we can get better cures for cancer. We can address Alzheimer's and muscular dystrophy and all sorts of orphan diseases. So we need to strike that balance. And part of that is, how do we improve the market incentives? And so much of my research is how we can improve the incentives of the system. That way we end up with the outcomes that we want to see.
Yeah, great. Good stuff. Omar, how about you? What are you spending your attention and mental energy on these days?
Thank you again for having me. I'm really excited about this panel. So as you mentioned in the introduction, I'm a surgical oncologist in practice in South Florida. My office is based in Fort Lauderdale, but I operate throughout Broward County and Palm Beach County. I actually was born and raised in Broward County, so I did all my training out of state and some of the best institutions in the world. And I even did a law degree at the same time, and I really wanted to improve the quality of care and get back to my community. So when I came back down to South Florida, I always wonder, why is it that we have amongst the highest rates of cancer in the country, but we don't necessarily have access to all the latest treatments locally at home, close to where patients are? So in addition to taking care of my patients and serving them close to where they live in the health system where they are, I got involved in the American Cancer Society, focused on issues such as quality and equity and access to not just the latest treatments, but also clinical trials. The exciting thing, and this is an oxymoron, but the exciting thing in cancer right now is that advances have really progressed rapidly. So from looking at how do we prevent cancer, what type of screening program we should put a patient on, how do we treat them and potentially cure them, and how do we guide their survivorship plan after treatment. All these advances in molecular and genetic type of testings and therapies have evolved so that it's a major game changer. The barrier now is, from my perspective and the perspective of my patients, is how do we get it to the patients? And in 2022, we have access to the technology. Just a matter of how do we make it work, essentially, so that it can actually be executed at the community level. And I think the lesson that we learned recently, and we're still learning it during the pandemic and the whole launch of the vaccine, is that if society marshals its resources in a way and uses science, kind of like the moonshot type of approach, we can achieve a great deal. And I think the challenge is, how do we work with different stakeholders to make this achievable, make it sustainable? And my goal as surgical oncologist is to prevent and cure every single cancer that we possibly can. And I think more and more we can get closer to that goal. And ideally, it should be close to home. It should be affordable. We shouldn't have a pandemic limit a woman's ability to get a mammogram or someone to get a colonoscopy because our system is inefficient. And so I think, for me as a cancer surgeon, because we haven't cured cancer, the onus is on me and that's why I do clinical trials, I do research, I do training, and I also do clinical practice, because we have to all come together to solve this problem. And that's why, again, I'm so thankful and excited to be here with you. But that's essentially what I'm focused on.
Yeah, good. Well, I am really appreciative that each of you are making time to be with us. Thank you. The idea of this conversation is that we will round up 5 slides. Our guests will bring some slides with them. We'll add some slides. And these 5 slides will serve as a graphical display of a key question or topic that we want to wrestle with together here in this next now 45 minutes. So across the sort of landscape of this policy and market question about the implications of new medicines, we've curated a couple of different images for you. We'd encourage you to chime in the chat box on the right of your screen. That way, as you make questions or comments or observations, I can integrate those into our conversation here together. So in this first slide, this is one that we've contributed to the conversation here from State of Reform. I think this is really a fortune-telling slide. This is a tale about the future rather than the past. It's an indicator of the new medicines that are working through their way through the clinical trial phases and on their way to full FDA approval. Certainly, many drugs that enter into this clinical phase pipeline don't come out on the other side. They are not approved. But if you look at this breakdown, you see 2, I think, really extraordinary things. One is there's just a massive number in absolute terms of new medicines that are first in class, meaning they are the first or novel way of dealing with challenges or symptoms or root causes of disease. There's a massive number of in terms of absolute numbers of new medicines, first in class medicines working their way through the R&D pipeline. The other thing I think that's telling here is when you look in relative terms, in other words, the number of new medicines as a total of all of the medicines that are working their way through the clinical trial, you'll see that there are a lot of new medicines in relative terms, meaning there are a greater percentage of the drugs working their way, the medicines working their way through the pipeline are now these first-in-class new medicines, whether they're biologics and large molecule or gene therapies or otherwise. So it seems to me that policymakers, Wayne, I'm coming to you first. It seems to me that policymakers have this kind of bow wave of issues heading their way in terms of new medicines hitting the market, even if it's significantly diminished than these in phase 1, phase 2. And so I'm not sure policymakers are as up to speed and as sophisticated as some of these new medicines working through the pipeline. What are your thoughts on this slide when you see it?
I think what you said there is absolutely correct, especially when you get into some of the more expensive gene therapies or things of that nature. I look at this from an economic angle, and one of the things that we're woefully unprepared for is, we're talking about therapies that are incredibly impactful. I mean, I know clinicians try to kind of avoid the term cures, but we're getting very close when we talk about some of these therapies of reaching that ultimate goal. It's incredibly risky. It's incredibly costly to produce. And so we're talking about numbers that are just incredibly expensive, incredibly high value. And our payment system is yesterday's payment system. If we're not able to work that through the system so that we can afford it, part of it is extending the payments over time. You don't buy your house by putting down the $300,000 for your house all at once. It's mortgaged over time. How do we actually make insurance mitigate the risk? And there's ways that we need to use insurance or possibly reinsurance as a means to mitigate risk. But we need much better risk management on the health insurance side, and we need much we need reforms in payment innovation, because when I look at that chart, I say to myself, that is fantastic. From a human perspective, we're actually getting medicines out there, treatments out there that can address progressive diseases that are horrible. And if we can cure those, if we can give people better quality of life, that's the purpose. And so what we need to do is we have all sorts of disincentives and inefficiencies that just pervade our pricing system, that pervade the insurance markets, and so the drug supply chain. All of these things need to be addressed so that we can marshal the resources to make these a reality, because losing these because of payment inefficiency is just a tragedy.
Karen, what are your thoughts on this slide, specifically about paying for these new medicines as they work through the process, and reflecting on Wayne's comments?
Yeah, lots of thoughts on the slide, and certainly what Wayne just said. And Wayne, how interesting that you use the term mortgage, because we have had that conversation too, because we have a lot of employers in our membership who have high turnover. They might be in tourism or restaurants or hotels. And they really have to question, I think going back, almost 10 years ago with the Hep C drugs, right? To pay, this huge amount to prevent having a transplant, down the road. And maybe this person's only going to work for them for several months or only a year. And we've been trying to brainstorm around how to have a more value-based process for reimbursement. And that term, mortgaging and likening it to purchasing a home has come up. A lot of these new drugs are often priced at levels that really do limit access, not only for the uninsured, but the underinsured, meaning that they don't have sufficient coverage, based on their situation. Maybe they're in a high deductible health plan and they just can't do that out of pocket. So we really do lose the opportunity to experience the full benefit of all this innovation when we can't get the drugs to the people who need them the most. And then the other thought that I had, DJ, when you were talking about the slide, is that many of the new products, and you can see it on this slide too, they are not innovators. A lot of them are new versions of existing products, and they really only offer a modest difference to their originating drug. And some people call them Me Too drugs. So we haven't seen, and I have a slide that I'll show, that if there's direct competition, that hasn't been driving prices down. It just doesn't follow the normal economic expectation.
Omar, I heard Karen and Wayne use a couple of terms that I think are relevant. And I know you were talking about this before we started our show, that some drugs are full new miracles, and some drugs are Me Too sorts of drugs. How do you think about this slide in terms of the efficacy for patients, and how is that different maybe than 5-10 years ago?
Yeah, so there are a lot more options now. Interestingly, with the new technologies we have in terms of diagnostic testing, you can more quickly determine which treatments are going to work or not work on patients. I mean, there are plenty of anecdotal stories of patients being forced to fail chemotherapy first, for example, even though they know it's not going to work, even though they know that the side effects will be worse for the patient, but they have to exhaust those quote unquote standard therapies before they can go to the next line of treatment. And it's obviously inefficient for society, for the payer, and then obviously more importantly for the patients to go through that treatment. And imagine yourself as a provider where you know you have something that can work better than another. There are data available where you can help answer that question. Is it worth pursuing this treatment or not? Fundamentally, you know, one of the challenges we have is that what is health insurance? It's supposed to help pay for healthcare, right? And so you're insuring against the certainty. Everyone's going to get sick. Everyone's going to die. So how do you manage that in a way where you're actually providing care? Even high deductible plans, they should be for, you know, disincentivizing things that are being done that are not medically necessary, not providing cancer treatment. You know, so there's certain things, and I'm sure, you know, Wayne can speak better as a health economist than I on this, but one of the challenges is that, you know, you have a situation where you have a treatment, like let's just take Merkel cell carcinoma or melanoma, where the treatment has drastically changes. We actually have something that works. We didn't before, and they were treating them anyway. And so now you're in an institution or in a setting where you have a treatment that should work well for your patient, but either because of the payer or because of the hospital, they're not willing to incur that cost for that treatment. So even though it's medically necessary and there's strong data behind it, in terms of getting into the weeds of the different types of therapies available, that's where exercising that clinical judgment, looking at those data to see, is there really going to be a difference or not? That's where that plays into it. But oftentimes you don't even get to that point of this discussion, to be honest, because it becomes such an affordability, such an issue that even if you have a treatment that should work, you just can't get access to it.
Yeah. Karen, I want to jump to your first slide. This is a slide that looks like comes from a drug pricing investigation out of the U.S. House of Representatives. Why don't you walk us through what you have here?
Sure. This is a staff report that came out last year in May, and this is going back to what I said a couple minutes ago about how normal, economics are not in play. If you have more competition, you hope that will drive costs down. And so this shows Humira and Enbrel and the price of an annual course of treatment. And AbbVie's largest competitor for Humira is Enbrel, that Amgen created, and it's for rheumatoid arthritis and some other conditions as well. So instead of these manufacturers pricing their drugs below one another, one or the other, to gain market share, as you would expect, right, in a competitive market, they engaged, or at least this group that investigated it alleges that they engaged in a practice called shadow pricing. And so they consistently followed each other's price increases. So as a result, both of the companies, repeatedly raised the price by what looks like almost identical amounts. So since Humira was launched, and you can see back in 2003, AbbVie, and before that was Abbott Labs, has increased the drug price 27 times. And it's a 470% increase. And we've had the conversations with the manufacturers, and they tell us that the employers, self-funded employers, are receiving rebates and discounts. But even when you net it out, the allowable charges that the employers are paying, either on the prescription benefit side or on the medical side, have still remained high and continuing to increase. And we also, hear a lot about this covers the R&D as well, to be able to have the higher prices. So, we know that patients and the employers in the United States pay a lot more for these drugs than patients do in other countries. It's about 256% more than like industrialized nations. And again, the argument back from the manufacturers has been that we here in the United States gain greater access to cures as a result. But I've read articles that have said that these other countries have they have meaningful drug regulation and cost containment, and they don't suffer from a lack of innovation. So we really have been trying to draw attention to what might actually cause some competition and the price to go down. And biosimilars are going to come out fairly soon on these drugs, and we hope that will provide some level of cost relief. And there are a lot of barriers to biosimilar uptake. I know we'll probably be discussing that later. And we have been spending the last couple of years working with our employers to make sure that their benefit design, that their formulary does accept biosimilars. We have a lot of challenges counteracting what's being told to them by the health plans and the PBMs. They're saying that they are inferior products, or they're going to lose money if they have biosimilar uptake, and that's because of rebates. We have a lot of providers who really are hesitant to stock the biosimilars because it's expensive inventory, and if they don't know that it's going to be covered. So we've been addressing all of these different issues over the last couple of years, really in anticipation of these biosimilars coming out for these two drugs.
We'll talk about biosimilars more here in a second, but Wayne, I wonder, is shadow pricing like this, or what is, I guess, alleged in this investigation to be shadow pricing? Is this something common you see in medical economics, or is this unique to maybe just pharmacy, or what are your observations here?
There are definitely unique factors when you're talking about Humira and Enbrel, and there have been approved biosimilars for many years. We're going to get Humira's biosimilar out in 2023, and that, when we talk about biosimilars, you'll see that type of competition works. And so when we have that introduction, we really should see that reduction in costs that we've seen. A lot of the problem when you talk about pricing, I mean, there's a lot here in this chart. If I can go one thing, when we talk about comparisons, I think it's always very important to do the comparisons on an apples to apples basis. Like when people talk about pharmacy and how much we spend on drugs compared to other industrialized countries, but the actual premium we spend on drugs is less than the premium we spend on overall healthcare, which doesn't mean that there's not a problem. What it means is that we have a systemic problem. And that systemic problem is again, we're going to the insurance system, how we don't separate out actual insurance in terms of risk, and then how do we pay for actual service, kind of, when you do your routine checkups and dealing with the more routine medical expenses and innovation in delivery. And it's those types of reforms that are going to meaningfully improve our quality and meaningfully kind of arrest the cost rise that we're seeing. So, when you talk about, you can't really talk about these things in silos. You have to look across the issue systemically. But diving into kind of Humira and Enbrel, undoubtedly, I think there's been a lot of games that have been going on, issues of rebate walls, things of that nature that have really made competition difficult and have led to some of these price increases. However, that is as much a function of our pricing system. And so I think when you get bad outcomes in economics, the important thing is to look at the institutional structure, look at what the incentives are, the system that drive those bad outcomes, and then how do we fix that? And I think that's really where our focus needs to be. How do we fix the supply chain? How do we fix the incentives of the system so that doctors and patients and the incentives that they have is what drives the demand side of the economy, not insurers and payers. And I think if we can get to that point, a lot of the issues that we're talking about now are going to be addressed.
Yeah. Omar, I'm wondering how your focus is on quality appropriately, and your work at the Cancer Association reinforces that. But how do you see cost coming into play when you are with the patient? You referenced cost in form of utilization, meaning sometimes it doesn't make any efficacious sense to run through a chemo regimen before you get to a different, regimen for a patient. But I just wonder, does the financial health of a patient factor into how you think about some of these medicines, or where does that come into play?
Yeah, it does. I mean, there's studies that show, unfortunately, that in our country, cancer patients are more concerned about going bankrupt than dying from cancer. Okay. And it's shocking to hear it. Every time I talk about it with patients, it's shocking because, as you can imagine, death from cancer is not a pleasant thing either. So that's where we work with other organizations like the American Cancer Society, Gilda's Club, social workers, et cetera, to be able to get access to these patients. Many companies will offer free or highly discounted services to patients if there are issues with their ability to pay. But even something as simple as getting a patient to their treatments. The American Cancer Society has a service. I mean, it's been hard with the pandemic, obviously, but they work with Lyft, for example, and ride sharing types of activities. There are groups that provide food to these patients. It's just something where we talk about these big, sexy drugs, right? But in terms of just the basic fundamentals of getting cancer treatment, getting imaging done, there are major barriers. And I mean, a lot of it, I think, goes back to what Wayne is saying. So this is definitely ripe for reform to figure out how we can achieve this. But it's a major issue for patients in terms of getting just basic, surgeries that don't even require insurance authorization for melanoma. It's hard to get that done for patients because of the way their insurance is set up, where they can get their surgeries done because of the insurance plan that they're on. Now, obviously, we're focusing on the bigger ticket items here, but there's definitely a big gap. And again, when you talk to a lay person out there, they think, well, I have health insurance, I have cancer, why am I getting the treatment I need? And unfortunately, it's not that simple. And then the other part of it that we don't really talk about, even for the patient with great insurance, with great coverage, the system is so complex to be able to navigate. The health systems literally hire navigators to help them through it. That's just to show you how much the system is in need of change. So for us as clinicians, we're developing these resources. We're reaching out to the companies. We're reaching out to the health systems and the different community organizations to try to get those resources available, because we can't just give somebody, hey, here's a diagnosis, write a prescription pad, get a PET scan or get a surgery or get a treatment. We have to help them get through it. But it's a major area. When you talk to physicians who leave the field, why do they get burnt out? And it's because of these types of issues. They're spending a lot of time trying to address this challenge. I mean, medical oncologists are spending, even at the best resourced systems in the country, are spending more and more of their time, instead of taking care of patients, trying to address these administrative challenges. And I know, in the anecdote I gave you of the patient who needed the chemo before the immunotherapy and got a great response to the immunotherapy. I mean, he was quote unquote cured or close to it from advanced colorectal cancer. He was treated at one of the top cancer centers in the world in our state. So it wasn't that he was in a community little program somewhere. It's just that these are the barriers that we're dealing with.
Karen, I want to jump to your next slide. I appreciate you bringing two. Tell us about this data set and what your members are talking about.
Sure. So we did a survey in the fall to kind of see what was on their minds. And you can see here, we've got just a couple of questions from that survey. And really, we were trying to get at, what's threatening their ability to be able to continue to be self-funded and to be able to have, hopefully the rich benefit design that they know will ensure that they have, a healthy and productive workforce. And you can see on there that drug prices, 80% of them said that was a significant threat. And it's less than hospital prices, though. So I guess to Wayne's point earlier, about drug costs and, where they are in the scheme of things in the cost of healthcare, that really is the top issue. But I will say also in hospital pricing, drug prices are embedded in there on the medical side. And especially when you're talking about specialty pharmacy and these biosimilars, there's a tremendous lack of transparency, which you see up at the top there, right? 60% say that's a significant threat. So there's a lot of concern around the issues that we're talking about today. And we also wanted to know from a policy standpoint, the potential policy opportunities that have been kicked around. And this was last year before surprise billing was signed, sealed, and delivered. So you can see, though, that 80% of them said there needs to be some level of regulation in drug pricing. And when we probed a little bit further, they said, anything that could put a cap on the inflation from year to year, for example, would be significantly helpful. And then you can see certainly some level of regulation on the hospital side as well. When we specifically asked them about payment reform strategies, they really, not very many of them have been able to adopt biosimilars, and they are working towards that. A lot of them need more information. There is a significant percent of them who have put in different processes for specialty pharmacy management. And I think, Omar, a lot of them have had unintended consequences. And we've been looking at those, whether that's step therapy and prior authorization. So we've made sure that they know to go back to their health plan partner and say, let's not prescribe to this fail first mentality. And especially when we have precision medicine opportunities and these lab tests that can really be very specific about whether a therapy is going to work or not. So I've seen in the 10 years I've been in this position a really big shift from, get all of these steps in to keep costs down to, are you creating a situation where that patient can't get the drug? Maybe they're hospitalized or even worse. So, we've really seen a shift in understanding value and having the patient experience as part of that. So I do want to, acknowledge all the things that you just said, Omar, previously about the challenges that the patient faces, and the employers, as much as they're paying on the medical side and the pharmacy side for oncology, it's actually dwarfed by the costs of disability, long-term, short-term, absenteeism, diminished productivity, wage replacement. So they are starting to feel a lot more motivated about providing navigation services, helping with transportation and childcare. And I think COVID has really presented an opportunity for folks to work from home more so than ever before, who have jobs where, you can actually do that. They were really pretty adamant about not having that kind of flexibility, but people had to turn on a dime about 2 years ago and be able to allow that to happen, and have found folks to be productive. So there's a lot going on with them right now, but bottom line here, the drug price situation and certainly hospital pricing top the list.
Yeah. Omar, what are your takeaways when you see the feedback from Florida's employer community?
I agree. I think they definitely see it's a challenge. And what's concerning too is that's something we're not really talking about right now, but the increase in cancers in the younger population. So when you think about the economic impact to employers, that's a larger cut of the workforce that can be impacted by it. And part of the problem, obviously I'm focusing on cancer here, but part of the problem with cancer is when you look at loss of productivity and loss of quality of life, somebody with heart failure, by the time they get to that point, they're already pretty disabled, unfortunately. Oncology, most of the time, the patient is normal. And in many cases, peak productivity in terms of what they're doing in society economically. And then boom, they get hit by this cancer. And that rate is increasing. So I know there are efforts to look at prevention and early detection, but that also with the new therapeutics, the new molecular diagnostics, to your point earlier, Karen, many payers won't cover those tests. Even things, forget the more expensive molecular diagnostic tests. A woman has breast cancer, just checking hormone status on those tumors. Not everyone's getting that covered. And that definitely guides treatment. And that's been standard of care for decades. It's not something that's new. So there are definitely, there are areas that, where there are different, some patchwork where, where the basic area is almost more like a floor than a ceiling that needs to be addressed. But I know from the circles that I walk in that cost is definitely a big issue, especially these high cost drugs. But the whole system itself definitely, I think, can benefit from some sort of reform in this area, and really tying, and we're open to, as from the clinician side, really having more accountability, making things more data driven. There was a study recently in terms of from our oncology society in Florida, where they looked at pre-authorization for cancer treatments, and based on their study, at least almost 100% of the cases were completely authorized. So It wasn't like there was a large number of cases that were unnecessary cancer treatments medically. So why are you creating those extra barriers to get the patient treated, which can have an impact on the patient? Are you really improving resource utilization, or are you just creating more barriers?
Exactly.
And that's
an area. Yeah, I was going to say that example is exactly the type of thing that we get in front of the self-funded employers to say, make sure, well, certainly if there is a prior authorization, that's done in a very timely manner, right? But in the cases, look at the data. Is it approved every single time? If so, then get rid of it, because it's a standard, as long as you have like the NCCN guidelines and standard of care that are being followed, there's no reason to put that barrier up. You're delaying the time that person is getting care. And I think for years, the employers really were very hands-off with oncology, didn't want to do anything in that space that they didn't feel 100% confident about. And now they are really doing more to manage cancer and to try to do it in a way that their plan member, their employee, or that family member that's covered is not experiencing these barriers that could have, as I said earlier, unintended consequences. So,
and part of that unintended consequence, when you look at like prior authorizations, you have medical practices that they have to hire administrative personnel just to deal with the prior authorizations. So if we're talking about why is healthcare so costly, when we have to hire people just to deal with prior authorizations, the vast majority of which are just kind of just shepherded through, but you're going through all this administrative details, and you're not even doing it in the most efficient ways, where often you have computer systems that could be less timely to fill out, but they're not being used. They're being used. So it's an inefficient, excessive burden, and it really is driving up costs. And it's also surveys, and Omar could speak better to this, but it's also a factor that drives people out of the practice of medicine. Nobody becomes a doctor because they want to fill out forms, right? You become a doctor because you want to help people. And when your day, 20, 30% of your day is spent on this administrative stuff, it's very dispiriting.
I want to jump next to your slide here, Wayne. I know we've talked about biosimilars in our conversation so far. Walk us through what you have here on this slide.
Oh, absolutely. This is something that at the Center for Medical Economics and Innovation, we track just because we believe that competition really is having an effect in the biologic space, right? These are the high value, high cost medicines, particularly in oncology. And what we've seen is, like Humira and Enbrel, right, are originator products without biosimilar competitors. And they're also the most expensive products, most money spent on those. And we don't see competition there. When you look at the 7 drug classes, not including insulin, but the 7 drug classes where we have biosimilar competition, some of which for many years, what we've seen over time, right, go back to 2018, and there was very little biosimilar share. And you're looking at prices compared to prior to competition, which I think we can come back to that, prices that are down 30, 40, 50%. So competition has driven prices in half. And over that time in these classes, particularly for Zarxio compared to Neulasta, huge increase in share. So that biosimilars now are generating, relative to what the prices would have been, $8-10 billion worth of savings. We can get, multiples more, not multiple, but I think another 3-4 billion more once we get biosimilar competitors with Humira and Enbrel under the assumption that the market situation would be replicated, so that we would get this 40-50% discount to the price, and we would see the share of that increase. Now, what's important in terms of the price and where we compare it to the quarter prior to competition is in the infliximab market, it's a perfect example. Remicade followed the prices down of Renflexis and Inflectra. so that in that competitive process, you've seen both the originator product and the biosimilar product drop their prices. So biosimilars haven't necessarily picked up a huge share, but the competitive pressures have done what they're supposed to do. They've brought down price. There's an issue in terms of follow-on innovation that would need to be addressed, but we've seen that competition works. That competition drove down the price. And in those markets where you see 70%, right, for what we talk about Zarzio, the originator didn't bring down their price, right? So the competition, the way it played out is you saw the biosimilar has a huge discount compared to where the originator is. Again, still generating significant savings when we look at the price gap. And so I think what we're finally beginning to see is that the biosimilar market is beginning to stand up. It's not where it needs to be yet. There's many more drug classes that we need to introduce the competition into. But in these areas where biosimilars have been introduced, a significant amount of systemic savings have been generated. And that's important not only because it expands affordability to kind of these current classes, but what that's also doing is now opening up resources. You know, we talked earlier about the innovations, and we had the chart about all of those new therapies that are working through the chain. And now by switching to biosimilars, we're keeping that kind of innovative ecosystem alive. And we're allowing the resources that would be going to paying for the innovations from several years ago to now be dedicated towards those new innovations. And that's the way the system is supposed to work, right? Where it was once where you had the cholesterol drugs were novel and those were expensive, but now no one takes a branded generic drug. It's a branded cholesterol drug. It's all generics, right? And so the money moved to these biologics. But now we need the money to move kind of to that next phase. And so we're beginning to see that progression. We definitely need to encourage that more. There's definitely payment barriers. There's the rebate walls I mentioned earlier, things of that nature that need to be addressed so that we can really reap the benefits of the biosimilars savings and to keep the innovative ecosystem going.
Let me ask this sort of delicate question that I'll throw it out to any of you. You may know. I know it's one that we all think, but we never ask, which is, how do these drugs get named? Do any of you know how these names, how we get
foreign language?
It's really quite a creative process to land on these kinds of names. Omar, how are you seeing a change among your peers in the use of biosimilars in the last year or two compared to 3 or 4 years ago? I'm wondering about this, the right side of Wayne's slide here and the increase in market share.
Yeah, I mean, so if you think about it, just at a basic level, when a doctor, even if it's a primary care doctor thinking to prescribe a patient a medication, many times based on their insurance, it'll, whether it's a certain antibiotic or a different type of drug, which drug they prescribe the patient might depend on the out-of-cost payment to the patient, what their insurance is willing to cover. So at a basic fundamental level, providers are doing this already. And then when it comes to the more sophisticated area of biosimilars and these biologic types of therapies, the providers are looking at how these molecules work. And so if you have something that's similar, I mean, going back to the name, right, biologically working the exact same way, essentially, and you have data supporting it, then what you're basically doing is providing an opportunity to increase access to patients to get access to these drugs that are equal efficacy. So it's essentially, it doesn't matter which one potentially you're on, as long as the data supports it. So if you look at it from that perspective, it's something that definitely providers are open to. And then you could even make the argument to pharmaceuticals too, like, look, it's another way for you to get more people to use your drug, even though if your overall market share might go down. If the pie is bigger, then you might be making more money. I mean, I guess Wayne could comment more on that than I, as a surgical oncologist, in terms of the economic impact of it. But yeah, for sure, there's definitely been, it's been one of those things where at some of our meetings at the state level, we've had discussions at our board meetings where physicians are bringing up the question, when can these similars finally make it? They're asking that question because they want to get more patients access to the treatment. Again, it's frustrating, obviously, and heartbreaking for the patient But for the provider, when they're in a situation where they feel like their hands are tied because they can't provide someone that treatment that they think is better for something that in their minds, again, these are physicians, nurse practitioners, they're not economists. They see it as purely an artificial barrier that's man-made. And, you can imagine the frustration and what that generates in terms of letters to their congressmen, et cetera, about how can we fix this? Because you get to a point where we have the technology, but we just haven't fixed the system and corrected those incentives to address it. But yeah, it's definitely something that they're open to because, again, it goes back to the biological question. And I think that next slide sort of shows that increase in uptake that you see as they're introduced.
We have one more slide that weaves nicely into this. This last slide shows the relative uptake of biosimilars as they have entered the market, and how the pace of that uptake, and notably there's a sort of difference in that pace of uptake if those drugs have been launched in the last couple of years versus years prior. And Karen, I'm just wondering if you have observations on some of we've talked about the obstacles a little bit, but what are the obstacles that you, as a representative of employers, what are the obstacles you're facing in terms of trying to get biosimilars to stand up, as Wayne puts it, in the broader marketplace?
Yeah, it's definitely been an uphill battle in the United States. We're way behind, other nations on the adoption of biosimilars. I read somewhere that 80% of the biosimilar market is outside of the US. So there's a lot more room to go here. But I think the major issues are that the PBMs and some of the health plans are telling our employer members that biosimilars are, in the end, more expensive because of rebates. The rebates are preventing the drugs from being adopted. And that's a problem because the development costs are high. And these are drugs that are intended to treat patients with very serious diseases. And the manufacturers of the biosimilar products are saying to us, we may not continue to produce them if we don't see more uptake. The PBMs and some of the health plans are also telling our members that biosimilars are less safe than the originator product. So we've spent a lot of time in bringing technical experts in to explain to them that that is not the case. They are clinically the same. And so they're basically told you don't have to include them on the formulary because you're going to lose your rebates if you do that. And that has really been the sticking point because employers like to get that check back from the companies with millions of dollars in rebates. But when we've peeled things back to show them on the medical side, they're not even getting those rebates. They can't pass savings on to the patients because the health plan is keeping those rebates themselves. And their reason that has been given to many of our employers is, oh, well, you don't pay us enough on the administrative side, so we need to, make up the difference, and we're entitled to that amount. So we're going to see some contract language changes put in effect to prevent that. We just need more transparency all the way around. So it looks like the biosimilars, if we can get them in place, could be about 30% less than the reference product. And that should save these plans a lot of money. So it's, as I said, an uphill battle. I've been countering the incorrect information that's been coming to them.
We're running to the end of our time together, and I always like to end on a positive note. So I want to ask each of you, and I'll start with you, Omar, what gives you hope for health reform broadly in 2022? What are the things that you look at that say, you know what, more of that would really be beneficial for us all?
Ironically, I think the pandemic has really opened folks a lot of eyes about what's wrong with our system, what the opportunities are. The latest announcement about the moonshot, again, I think is exciting. The fact that we're having this conversation, I think, is exciting. When I speak to medical students, and I actually train quite a few in South Florida, and we do research, and a lot of our research is not just looking at the outcomes in care, but also what the financial barriers are. I'm seeing that the new generation that's coming, that'll be taking care of me when I need it, that they're really in tune to these types of issues as well. And I'm hoping that all these conversations that are happening will produce that. This is definitely achievable. It's easier than removing a tumor, So it's just one of those things where we just all have to work together, continue the conversation, and find. It's kind of hard to find a pessimist and a cancer surgeon, right? So I'm pretty optimistic at baseline.
It's pretty optimistic to say that solving healthcare is easier than taking out a tumor. There is optimism there. Karen, how about you? When you look at health reform in 2022, what gives you hope?
Well, I've seen a lot more activity from the employers to drive value in healthcare. COVID certainly was overwhelming for them over the last couple of years, and they're getting back on track. They really become activist purchasers is the term that we're using, because they really want the best, not only for the employer, but for their employees and their family members. So really looking at right drug, right treatment, right price, right place. So I'm excited that we'll be able to move forward and hopefully see some real benefit across all of the constituents we work with.
Yeah, good. And Wayne, how about you? 2022 still lies ahead. What gives you hope about the year in front of us?
Well, I think we don't get enough attention. I think it's because if it bleeds, it leads type of news, but no pun was intended. We've had a lot of nice victories, right? Where we see the biosimilar market shares coming up. If you look at the actual inflation data, right? Actual prices in the inflation data for drugs are going down, right? In a time when there's 7% inflation, drug prices are going down. We're seeing telehealth, the different types of innovation in the delivery of healthcare. So I think if you look out in the landscape, you can see green shoots. Some of it was from the pandemic, but you can see reforms that are going to help patients, that are going to address costs. And so if we can build off of those, I think that's a reason for optimism, particularly take the telehealth where you can actually, people see the value of it. They actually experienced it. And so there's that now momentum to keep it. Right? It's hard to advocate for something when you don't really know kind of what it can provide for you. Now that we have that experience, it's one, you're going to have more people advocating for it and also being open to more reforms in delivery, and we're having the right conversation. So I think all of that gives reason for optimism.
Wayne Weingarten is a senior fellow and director for the Center for Medical Economics and Innovation at the Pacific Research Center. Omar Rashid is a surgical oncologist in private practice and the chair of the Southeast Florida Area Board for the American Cancer Society. And Karen Van Khalil is the president and CEO of the Florida Alliance for Healthcare Value. Thank you all for being with us. Thanks to our attendees for watching this. And for those of you watching online at stateofreform.com, we will continue to have this and other conversations available for you. Thanks for all the wind you put in our sails. We appreciate it. Take care.